Good evening, everyone. My talk is What's New in Thoracic Interventional Oncology. I'm giving this talk on behalf of Dr. Nathan Shetty, who is unfortunately could not make it to the conference due to some personal unavoidable circumstances. So we'll discuss, this talk will be very short. I will discuss majorly two papers. So as you know, the tumor ablation is divided into the chemical ablation and an energy-based ablation. Chemical ablation we don't do nowadays, it's percutaneous ethanol injections. And we majorly do a thermal ablation like RFA and microwave, and recently we also started doing cryoablation for lung metastasis. So this is our first paper which is recently published. It's radiofrequency ablation versus surgical resection for the treatment of oligometastatic lung diseases. So the purpose of this study is to compare the efficacy and tolerance between the radiofrequency and the surgery. And it's a retrospective study which is done on 2 institutions, and it is up to 5 pulmonary metastases with the maximum diameter of 4 centimeter were included, and there will no involvement of pleura and thoracic lymphadenopathy. And the endpoints were overall survival, progression-free survival, and pulmonary and local tumor progression rates. So total 204 patients, and surgery were done in 78 patients, and RFA was done in 126 patients. So if you see the characteristics of the patient who underwent surgery or RFA, if you see the age in RFA, the mean age of the patient was significantly higher, which is 62, and in surgery is 53. And also the radical treatment received in surgery group is higher as compared to the RFA, and bilateral tumors and extrathoracic metastases were seen more in RFA group. So these are the results. So if you see the local tumor progression at the end of 1 year, which is higher in RFA group, and pulmonary progression free time is similar in the both group. And if you see the overall survival is same in the surgery and the RFA group. And if in the adverse effects, the normal adverse effect, pleural effusion or the hemothorax or a pneumothorax is mainly seen in RFA group with a significant p-value. But if you see the hospital stays the patient take, it's significantly lesser in the RFA group as compared to the surgery group. And if you see the comparison between surgery and RFA in terms of local progression and pulmonary progression, slightly higher in RFA group as compared to the surgery. But overall, all these factors like progression-free survival, overall survival, they all are no statistically significant difference was found according to the treatment modalities. So these are some predictors for the local progression for RFA. If the number of metastases is less than 4, then it is a significant factor for the local recurrence. Also, if it is a metastasis as bilateral, it also appears to be significant for local recurrence. And if you analyze the size of the tumor for local tumor progression, if you do RFA for more than 2 centimeters, it's associated with the higher chance of local tumor progression. If you see a limitation for this study is actually RFA patients are being older in poor clinical condition, and more than third having still have their primary tumor in place. Sample size is smaller, and the study is underpowered to capture minor differences between treatment. Retrospective nature is also a major drawback. In conclusion, there is no differences were identified for overall survival between two groups in spite of unfavorable factors in RFA group like statistically older patient, overall more comorbidities, and more bilateral lung diseases. In conclusion, RFA for oligometastatic lung diseases without pleural extension or mediastinal lymph node can provide acceptable local regional content and overall an outcome survival to surgery, especially if the metastatic disease are less than 2 centimeters. The other paper, it's microwave ablation. It's a new paper just published in 2022. Which shows the microwave, it's a comparison study between microwave ablation plus chemotherapy versus chemotherapy alone in advanced non-small cell cancer. Is the multicentric randomized control phase 3 trial. So objective of trial was trial was performed to verify whether the microwave ablation in addition with the chemotherapy could provide superior survival benefit as compared to chemotherapy alone. So, it's a treatment naive patient with pathological verified advanced or recurrent non-small cell cancer were randomly assigned to microwave ablation and microwave ablation with chemotherapy or chemotherapy alone group. And the primary endpoints were progression-free survival. Secondary endpoints include overall survival, time to local progression, and overall response rate. So these are all the flow chart of the patients. It's 293 patients, which 148 assigned to the microwave plus chemotherapy and 145 assigned to the chemotherapy group. In the result, the median follow-up period was 13.1 months and 12.4 months. Median progression-free survival is 10.3 in microwave plus chemotherapy group and 4.91 in chemotherapy only group. So this is significantly higher in microwave plus chemotherapy. Median overall survival not reached in microwave plus chemotherapy group and 12.6 months in chemotherapy alone group. Median TTLP and objective response rate was similar. The adverse events are not significantly different in these two groups. So in conclusion, in patient with advanced non-small cell cancers, longer PFS and overall survival can be achieved if we combine the treatment with microwave ablation with chemotherapy as compared to chemotherapy alone. So some recent advances in tracheal stents. So now we have a silicone and the metallic stents, but there are a lot of research going on in drug-eluting stent which prevent granuloma formation, and biodegradable stent we have made for polydexanon that degrade when placed inside the vein, making ultimate bronchoscopic extraction. One more advances are customizable 3D printed stent. If you see, a lot of patients have extensive compression and the trachea is deviated. So on basis of CT scan, they made a customizable stent to reduce the migration and granulation tissue formation. So okay, so thank you for kind listening. Thanks.
Which is better, RF ablation or microwave ablation, in terms of pure ablation, not with respect to the chemotherapy alone or with chemotherapy, but the results regarding the margin and the extra coverage. So it is going to be, and which is better delineated on imaging regarding ablation?
I think if more research is like data we have available is for microwave ablation, which is more efficient in lung cancer in lungs. So and we also see the quite higher uses quite higher power. So in our data also the microwave have more local tumor control than RFAs. So, and for the margins, I think they have started using cryoablation nowadays, which we can see clear margins between the tumor and the margins of the ablation zone.
So any size difference between the three modalities regarding the coverage of the maximum tumor size that can be covered?
So the microwave ablation we can achieve up to 5 centimeter. We can do ablation for ablation if using microwaves.